So I am really, really pleased to be here this afternoon. I would say so far, all but one of my presentations has been more research focused, where this is definitely more clinic focused. I did talk about symptom management, specifically pain and constipation among cancer patients, another afternoon, but the vast majority of talks have been research focused. So this is going to be again more of a clinical focus. It also is going to be more of a discussion. So I'm going to apologize a little bit in advance for those in the Zoom room because we will be doing a little more discussion as we move along. So my PowerPoint presentation is not as informative. Maybe that's a good way to frame it. It's not as informative as what more of a lecture, without a clinical input discussion. So if you look at the PowerPoint, it's not going to have the details that most of the other PowerPoints that I have shared have, because the expectation here is that I am going to be asking you questions and we're going to be doing clinical judgment together. Um, and so that is not in the PowerPoint. Um, the you don't have to be nervous. You really don't. And see, now those in the Zoom room are all going, woohoo! We don't have to unmute and talk. We chose really well to be on Zoom today. No worries at all. But the reason I suggested this as a topic of conversation is when we were talking about, the care of older adults and we were communicating before I came. I said, for me, in my clinical practice, I'm director of palliative care for the UI Cancer Center. We use this ethical framework to recommend what sort of care when we do our palliative consults. So that's why working together, emailing back and forth, this is kind of the topic that we ended up coming up with. So thank you for this opportunity. The other thing that I'm going to say is I did only plan an hour and a half for this presentation. So I expect that will be ending at about 3 o'clock today with this presentation. So maybe that's enough of an introduction that I can get started, or shall we just find out who's in the Zoom room? Um, what do you think? Well, maybe I should say, is there anyone who has not been part of one of my previous talks or discussions?
I'm not sure, but five or six of them, it
Mhm.
be my master degree student
Okay.
and gerontological nurse practitioner
Okay.
because this is an assignment for them.
Ah,
Because it's part of it should be one of
sounds
that
like
topic.
professor anxiety, not student anxiety.
It's just like they want to do something because it's a part of the topic in our course study for this semester.
Excellent. Well, why don't we have anyone who has uh, seen me before, been to a lecture before? You don't have to reintroduce yourself, but anyone that's new to me, if you can introduce yourself, that would be appreciated before we get started. So, the first thing I'm going to do is just very briefly go over some palliative care basics. And then I'm going to describe some basic ethical principles is the second kind of piece of what we'll be talking about. And then the third piece is after we have this understanding of palliative care and basic ethical principles, we're then going to go and talk about a clinical ethical decision-making tool. So those are really our three learning objectives for this afternoon, for this hour and a half. So what is palliative care? Well, number one, it's surprisingly difficult to define. Um, and the reason is that it's not defined by a body system compared with like dermatology, which is the skin, or cardiology, which is related to the heart. And um, uh, it's also not defined by what is done, like anesthesiology or surgery. It's not defined by age, like pediatrics or geriatrics, although today we are focused on geriatrics. Um, and it's not defined by location of care, like ER or critical care. So you're going, ha ha ha, okay. So you're telling me all that it's not defined by. So it's any illness, any age, any location is palliative care, or where palliative care can occur. So it took a lot of time and effort, really, to come up with a definition for palliative care. And the definition that I use is the World Health Organization definition, which says that palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness. Okay, and this is important because often people think of palliative care and end of life, but that's hospice care. Palliative care is life-threatening illness, or what I like to think of is non-curable. What I always think about or do is focus on something that can't be cured. Through the prevention and relief of suffering, so you're focusing on quality of care. Again, the prevention and relief of suffering by means of early identification, impeccable assessment, and treatment of pain, which is why I focus on pain, because it's one of the most prevalent and most problematic symptoms for palliative care, and other problems, because it isn't just symptom management, but also physical, psychosocial, and spiritual. So you could see that palliative care is pretty broad. Okay. So basically, palliative care is the what if, is what I like to think of it. So, what if, and I am really sorry to say that the printing in black isn't showing up very well. So, I very, very sorry about that. But what if we take the path less traveled? Okay, we're not disease-focused care or aggressive care, but where the other path is the palliative care path. And so what palliative care does is it can help inform the choice of not intervening with aggressive care, but rather focusing on not curing or aggressive care, but focusing on improving quality of life. What if? Good. Now we're going to be able to read the text a little bit more. It was like I looked at the slide and I went, I thought I did this different. Okay, I hadn't clicked far enough. So, what if things look like? What about the time frame? Where might the care take place? What should the patient family expect or perhaps demand regarding care? And how might the palliative care team help the patient family, and we also help the healthcare team make the decisions. So that's usually what a palliative care consult happens and what we help with. Okay. When you are writing a grant, the first section that you really start taking a look at is the significance section. How serious is the problem? So for oncology care, we say 1 in 4 adults are going to have cancer. Well, that's pretty significant. Okay. For cardiology, sorry, I don't know the real statistics for cardiology, but let's say 1 in half, 50% have will have cardiac problems. Okay. So that's how we start with a significant section for a grant, is we say, how big is this problem? Well, when you think of palliative care and you look over time, look at today, look at the beginning of time, and you look at from 0 to 100%, okay? If you haven't figured this out yet, my significant section is really good because 100% of people from the dawn of time to today are going to die. So everyone needs palliative care. So let's put this relevance in context here. Heart disease. I did remember it right. 1 and 2. Woohoo! um, Cancer, 1 and 3. Alzheimer's, 1 in 2.5, or 1 to 5 by the age of 85, because we know with Alzheimer's disease, it increases with age. Diabetes, 1 in 5. Parkinson's, 1 in 40. Okay, so putting this relevance in context, this is why palliative care is so important, because it is for everyone. So when we look at palliative care as a philosophy of care, okay, you want to kind of take a look at. Oh, sorry, I clicked a little bit too quickly there. Um, you want to take a look at the available services that we have. And as I just said, because palliative care is for everyone, but the available services are not available for everyone, we really do have to limit a little bit who we deal with. So even though as a philosophy of care, as I just talked about, we really want to reach as many as possible, and 100% of patients need us. The available services are not there. So one of the things that I have been involved in the United States is helping to educate and provide palliative care education for every provider. So we have our provider palliative care specialists, which is primary palliative care, but we also now more and more are including a section of palliative care for every nursing program all across the country in the United States. So secondary palliative care that every nurse is trained in palliative care, because our available services, for palliative care is limited. Okay. This is an evolving model of palliative care, but I think it's becoming fairly common and clear with palliative care. Is that first, when we started talking about palliative care, it was more like the hospice model, where you're pushing, 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 pushing active treatment, and then it's like, okay, we can't do anything more. Okay, we'll refer you to hospice or palliative care. And and for hospice care, again, in the United States context, in order to get hospice care, you have to have two healthcare providers say that we would not be surprised if you would pass away in 6 months. And that's when hospice benefit clicks in. However, I am very happy to say that really we're more now in this model of care. So palliative care starts at diagnosis, and we go hand in hand along with the cure or life prolonging treatment. And palliative care, comfort or quality of life care, then begins increasing, increasing, increasing as you move on and get closer to death. The other thing that I'm very, very happy about is that recently what we have done is that we've added this bereavement piece. So we don't just end, at least for the hospice benefit in the United States context, with death, but we follow the person, the caregiver, for 6 months. We have a regular program of 6 months care for the caregiver after death, which is bereavement care. So this is really more the model of palliative care that we use now, certainly in the cancer center where I practice, the UI Cancer Center, is that I go and meet people right away when they're first diagnosed with cancer, especially if it's advanced cancer. And we know, like the glioblastoma, that I think I shared with you that my sister died from 2 years ago. So we know that there isn't a cure for that one. So right away, when someone is diagnosed with glioblastoma, then a person from the palliative care team, usually me, goes in with the healthcare team, and I introduce myself and I say, I'm from the palliative care team, and I'm here because we give an extra layer of support as you go through the process. And we're focused on helping you live your best life, to help you have quality of life as you go through your cancer treatment. Okay. One of the wonderful things about palliative care is we're concerned with the whole person. Okay. It isn't just symptom management, but we're focused on the physical, the emotional, the spiritual, the psychosocial. So I'm biased, as you probably have figured out, because I'm talking about my practice. But I think that when you're a palliative care advanced practice nurse, you're able to practice the full extent of nursing because you're looking at the whole person. And you're not so narrowly focused, but you really do get this holistic care that you're able to practice as a palliative care nurse. And you can see suffering here in the middle because we care about all suffering, no matter it can be and often is spiritual suffering, because what happens is, there really is that questioning of God that often happens, or a spiritual being saying, why? Okay, why am I having cancer? Why am I having these problems? Why? And especially with my younger, patients. There certainly is emotional. So there's certainly, you deal with this as a nurse also at the bedside, but in palliative care, I would say some of these other dimensions of a person you're dealing with much more when you're doing palliative care practice. So here again is really where we are right now with this model. And I like to think of us as an umbrella. Okay. So another way that so like I said, we're providing this extra layer or extra coverage of care is the way I like to explain palliative care. So when we talk about potential palliative care settings, and I kind of hinted this at the beginning, it's anywhere. Okay. When we were talking by email, it is the community, it is the hospital, it is anywhere, which is a wonderful thing about palliative care. Ultimately, it will affect every one of us. So there's large numbers. And I think one of the things that I have learned as I shared with you, a lot of the focus of my education has been educating providers on how to provide palliative care, no matter what their specialty, whether or not they're OBGYN, whether or not they're pediatrics, whether or not they're, any of the, specialties. Um, and we have our own death issues as care providers. Few, and this is why I've been focused on, educating for palliative care. Few physicians or nurses have even basic training, which is why we're working on this. And clinicians don't intuitively know when they need advice. Okay. We don't know what you don't know. That's true for all of us. So the process and outcomes are expected to be terrible. After all, it is death. So, how can you tell when something inherently horrible, such as death, goes badly? It has tremendous impact on those close to the individuals. So, there's the collateral suffering. There's the collateral suffering that certainly happens with the family caregivers, but also, quite honestly, with the staff. Okay, it's hard as a nurse when you lose a patient. Okay, that's one of or a physician, or any of the healthcare team. So there's a great deal of collateral suffering that you have to think about as well. And Um, for a lot of our patients, okay, what we're able to do is ask and check in with them. So, how was it? Okay. Would, and, but if the patient has died, there's no chance for feedback from the patient after the fact. Now, you can talk to the family caregiver, um, but this is another challenge for palliative care. Okay, now, why are we here today? Well, we're all here today because we're focused on gerontology or the older adult, which is why I was so excited when you reached out. It was like, oh, yes, because yes, palliative care is for everyone, OBGYN, pediatrics, but honestly, the vast majority of our patients are the older adult when we think about palliative care. So we need an adequate knowledge base, which includes ethics, which is another reason why I am so happy to be here with you today, because I think where ethical principles really, really comes in is when you think about ethics, you think about what should be done for the patient. And when you're talking about the older adult and when they're getting close to life, ethical principles become really, 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 really important. Okay. So we're going to talk a little bit now about basic ethical principles. So I'm going to pause a minute here and open the floor because what I did was really talk very basically about palliative care. But let me pause here and just ask before we get into these palliative care principles, do you have any questions about palliative care before I move on to ethics? Woohoo. Okay. Again, it was really just a basic overview. Um, as I have shared before, um, I teach classes in palliative care, and those are year-long classes. And so when I have an hour and a half and I'm giving just an introduction to palliative care, uh, you know that I'm not, it's a broad brush overview. Okay. Um, I'm going to also confess that when I teach ethics, it's a semester long class. So 15 weeks of 3 hours each week. So again, this introduction to ethics is a very broad brush uh, introduction only to ethics. So I'm sharing my limitations section to this presentation today. So what we're going to do now is really talk a little bit about some of the key ethical principles. And um, before we get started with this, what I'm going to say is some of these first ethical principles that I'm going to be talking about are some of the strong major principles that we use when we make healthcare decisions. So I'm not going to go through everything, but I'm going to be narrowing and focusing on the ethical principles most relevant to nursing care. So that's number one. Um, Number two, what I'm going to do is that the reason I'm going to talk about these ethical principles is that when we do ethics, again, from the US perspective, there's really two main ways that we do ethics. First of all is principlism, which is these main principles of ethics. So these are kind of the foundations. So that's why I'm introducing them to you. And then we're going to apply them in clinical ethics for a clinical decision-making tool. So that's why, again, this is a really basic understanding, but it's kind of the foundation that I feel like we need to have. So, first of all, what I said about ethics is we're looking at what should be done for the patient. Okay? the questions of clinical judgment is number one, what is wrong with the patient is our first question, which is our nursing assessment. Number two, what can be done for the patient is the next question for clinical judgment. Okay, but where ethics comes in is what should be done for the patient. Okay. So now what I'm going to do is talk a little bit. Let me just briefly introduce. So let me just go back here before I get into this and talk a little bit about where nursing ethics comes from. And it really goes back to Florence Nightingale, which is kind of, she's thought of as the grandmother of nursing in a lot of ways. And for Florence Nightingale, what she had was a Nightingale pledge. And that's really where nursing ethics started out. So I'll just read the Nightingale pledge to you. I solemnly pledge before myself, before God, and then in the presence of this assembly, to pass my life in purity and to practice my profession faithfully. I will abstain from whatever is deleterious and mischievous, and I will not take or knowingly administer any harmful drug. I will do all in my power to maintain and evaluate the standard of my profession, and I will hold in confidence all personal matters committed to my keeping and all family affairs coming to my knowledge in the practice of my calling. With loyalty, I will endeavor to aid the physician in his work and devote myself to the welfare of those committed to my care. So here you can hear this is where really ethics first came into nursing practice. And it is certainly abstaining from deleterious and mischievous. So that really goes to non-maleficence, and we'll talk about the ethical principles a little bit later. It also has certainly confidence, hold in confidence all personal matters. So talking about confidentiality and privacy. So that is coming into the Nightingale pledge as well. And devote myself to the welfare to those committed to my care. So this is really where ethics first came in. But also you can hear in this ethical principle, it really was aid of the physician. So it still was thought at this point in time that we meaning nurses, were a handmaiden, maybe I can use that term, to a physician. However, nursing really developed much more in about 1930. There was a case in the Philippines. And what happened here is in Manila, a nurse was found guilty of manslaughter and sentenced to a year in prison and fined 1,000 pesos, which was a lot of pesos back then, not so much today, for following a physician's orders. And so she was found guilty because when a doctor said cocaine instead of Novocaine, she did not question the orders and instead gave the cocaine. Okay. And the patient passed away. And so now in the 1930s, nurses then, this was really where we separated then from the physician, and we're no longer considered a handmaiden, but internationally considered our own profession with our own ethics, that nurses cannot just depend on what the doctors say. They have to know if the doctor's orders are correct. And then I would say, again, um, I'm speaking from the United States, but true for most countries, then we have in the United States, the American Nurses Association Code of Ethics. And I think you have the same thing here in Thailand and most countries. Well, all the countries where I know anyway have something like this that has developed. So just to give us a little bit of background, for nursing ethics. Um, and then the other thing that I want to talk a little bit about is the development of bioethics, because bioethics really is very important for elder care and for palliative care. So, as I shared with you, I was a professor at the University of Washington until about 6 years ago when I moved to the University of Illinois, Chicago, because I needed to take care of my parents and my parents-in-law because they were becoming more and more old and needing their daughter, who was a nurse, who needed to be a little bit closer by again. So after being at Michigan State, I moved out to University of Washington, Seattle. Well, Seattle was a little bit too far to come back to Michigan to care for my parents, so I needed to move a little bit closer. Well, bioethics, when in the United States context, really started out at the University of Washington. And it started out in the University of Washington with Dr. Scribner. And he was someone who took care of kidney patients, a nephrologist. And what happened at the time, and this was in the 1950s and 1960s, is that um, there were only well, this happens with cancer and chemotherapy as well. You can only poke a person so many times before the veins run out because they have been poked so many times. Well, when giving kidney dialysis to keep someone alive after kidney failure, there was only so many times you could poke someone, and he came up with the idea of, if I do a tubing, what would happen? Well, the tubing worked so because with the blood flow, it clotted. Okay, so it didn't stay open very long. So at that time, Teflon coated pans were just coming out, and he went, what if I coat the tubing with a little bit of Teflon? Then the blood might kind of slide through, and we'll be able to, keep this tube open and poke it more often, and then people can live with dialysis a lot longer. Well, that worked. And it was the Scribner shunt. But then the problem was there were only 6 dialysis machines. So how do you decide who gets dialysis and who does not? Very difficult. So that's why ethics is important. And that's really where bioethics started. And bioethics, so what should be done for each patient is really what you have to think about. And what happened was in the United States, they created a committee, and these committees were called God committees because, quite honestly, they were the ones deciding who got dialysis or who did not get dialysis. Okay. We make these decisions every day in healthcare. So let's fast forward to COVID. Okay. When COVID first started, what happened? Okay. Before we had our immunizations to hopefully prevent serious COVID, before we had any treatment for COVID, when COVID-19 was first starting in the end of 2019 and the beginning of 2020, a lot of people were dying. But one of the ways that we could extend life is by putting people on ECMO, which was the heart blood bypass machines, so that COVID would run its course through the body while the person was on the heart lung bypass machine. And then once the COVID virus became less, then we could take them off the heart lung bypass machine and they were okay. Well, just like the Scribner shunt and dialysis machines, how many ECMO machines do you have?
Because even here, it's a big university with the cardiologist department. The ECMO is just two, and three is in the CPAP. That's three overall here. One in Nakwaping Hospital.
Yep.
Over in Chiang Mai.
Yes. There you go. There you go.
Of the nurse
Mhm.
specialist, because we need perfusionists for the ECMO.
There you go. Ethics and palliative care. So this is when we do our ethical consultations as palliative care clinicians, is exactly these decisions. Okay? So that's what we're going to walk through today. So now that I've set the stage a little bit, now we're going to talk about the principalism. And what we're going to do is go through these basic ethical principles. So I have now set the stage. Now we can start with autonomy. So what is autonomy? It's the right of the individual to self-determination, particularly over one's body. So a person with decisional capacity has the moral and legal right to determine what will be done with their own person. So I have a question for all of you, and all of you on Zoom are going, woohoo. A patient who can no longer competently care for themselves, refusing their home setting, and all of you doing geriatrics has probably met one of these people, okay? Even though they might receive better care in a nursing home, do you have a right to make them move?
We have to ask for a presence with the legal make decisions for her, because normally the people have to sign who's going to be judged when the patients cannot decide it by themselves.
Correct.
Okay, I have a question.
Yeah, absolutely. Good.
Oh, I read the news from the foreigners.
Yep.
Older adult, the ladies, she signed DNR.
Correct.
And suddenly for the cardiac arrest at home.
Correct.
Her daughter or her son called 911.
Correct.
And the nurse come to home and start resuscitation, because as a nurse, we have to save the patient's life.
Correct.
But this nurse got fined from the nursing councils. Broke the patient's decision, DNR.
Correct. Thank you for bringing that up. So this is a little bit tricky situation in the United States. So I'll just explain a little bit more. With a do not resuscitate order, okay? If you call 911 and you ride the ambulance. So before I was a nurse, I was an EMT, which is an EMT, EMS is ambulance. When I got married, my husband said, and so I went into nursing. But I started out in the ambulance. if someone calls 911, okay, then we have to do CPR. Okay. But if 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 it is in the hospital and there's a do not resuscitate order, if it's a nurse in the home and there's a do not resuscitate order on the refrigerator, and we know about it, then if you start CPR, yes, you are violating. Yep. And yes, you can be sued um, as a nurse in the United States situation if there is a DNR and you start CPR.
Feel like as a nurse, and so it seems like an urgent that we want to save life
Of course.
because with our ethics, we do not do harm, we do a benefit, whatever that help our patients. Because I know that finally it's penalty that she had to give some training,
Yeah.
the retraining for some ethics or the LNAC, I thought, and then get some pay some amount of money.
Yes.
It's
Definitely a fine. Hmm.
it's big enough as a nurse.
Hmm.
It's,
Hmm. Hmm. Thanks for bringing that up. So, yes. So the person has the right over one's own body, so they can say, "Okay, we don't want um, CPR," and you have to do that. And in this case, if they can no longer competently care for themselves, okay, but have decisional capacity, then you can't make them move. Okay. But in some cases, and this is where you get into the legal case, if they are uh, causing harm to themselves, then what you can do is you can go to the legal system and have a ward of the court appointed, who then makes the healthcare decisions for them. But that's really challenging to do if they have their own decisional capacity. Yeah. But this is something every country, every world, every country in the world has to deal with because we have more and more elderly patients, and they want to, in general, um, speaking from my own experience with my parents, they want to stay at home, as long as possible because that's comfortable. Um, and so this is something, especially with geriatric care, you know, um, and providing care in the community is a question that we're going to have to deal with. So. The next two basic ethical principles we're going to kind of talk about hand in hand, um, because non-maleficence is do no harm and beneficence is doing good. So it's really it's easier to talk about them together rather than separately. So do no harm, remove from harm, prevent harm. So we as a nurse, we're required to remove and avoid intentionally causing patients unnecessary harm or pain. And beneficence is doing or promoting good. And I put this, here, preferably the patient's view of what is good. So, what the patient believes is good and what the nurse believes is good is not always one and the same. The DNR example that we just talked about is a good example of that. So. So one question that I wanted to ask you then is if we have a patient who has gangrene of the foot and surgical removal would treat the gangrenous affection, but also cause great discomfort for the patient who is most likely going to die soon. What do you think as far as non-maleficence and beneficence? Do no harm or promoting good. What would you do in this situation?
Yeah, it seems like he said it's on brink of the ethical dilemma
Uh-huh. Well,
because
that's why we're here today.
yeah, it's because it's happened. It's happened because it's for the kidney disease patients who do dialysis for over 10 years.
Mhm.
And the gangrene, it's come up in her food. And she said like she don't want to do it, but the doctor said it is a best way to amputate and save your life and go over with the dialysis. But we have to talk with the patients and her family about the good or the benefits of this procedure
Correct.
and the drawback.
Yeah.
I mean, the bad side, and make her and her family
Correct.
decide which one is good.
Correct.
Because for palliative care nurse, it's one question that pop up. What else you need for?
Yes. Yeah. So again, ethics, there is no right or wrong, which makes it really challenging. It's really gray. And it's all about deciding what should be done for the patient rather than what could be done. Yeah, for the patient.
This is a real situation
Mm.
where, and as a nurse, I'm so upset because finally the patients make the decisions against with her family.
Uh-huh.
This is a real case that happens in Thailand, though.
Uh-huh.
Because 10 years with
Yeah.
dialysis, she said like it's more the time that she spends her life with her family. But she decided stop dialysis and then return home and said, I want to die at home.
Yeah.
7 years, I mean 1 week after, because there's no dialysis and she passed away
Yeah.
at home.
Mm-hmm. Mm-hmm. So, as a palliative care, well, dialysis is one of the places I actually, as you know, work. um, um, there's three patient populations I take care of most regularly at UIC. Hemodialysis, the hemodialysis unit is right across the street from the College of Nursing. So, and thank goodness there's a good tunnel system, so I don't even have to go outside. I can tunnel under the road and get to the dialysis unit without freezing because it's cold in Chicago. um, Sickle cell disease is my other patient population, and then oncology. So, yes, I know the dialysis population really well. Yeah, yeah. And thank you for bringing that up because that's exactly the sort of thing that we're dealing with palliative care is that we would be called in. Um,
Then true education.
yeah,
Yeah.
yeah, yeah. Okay. Before we go on, there's one other principle that I'm just going to talk a little bit about, which is justice or fairness, and I'm bringing that up based on, kind of one of it made me think about this, which is the equitable distribution of resources. So that is something that I want you to keep in mind as well. Um, so then I'm going to just talk a little bit about um, some of these patient nurse specific principles. So those, I would say four. Really, autonomy, non-maleficence, beneficence are the main ones, but then also justice comes in. I would say those would be the core principles that we need to think about. These are now principles that are patient nurse principles, and that is veracity, which is honesty, truthfulness, and candor. the duty to disclose information. An example is the informed consent process, the duty not to lie. The example is not revealing a diagnosis or change in condition when asked. So I'm going to pause here, okay? Because when I practice in India and when I practice in Japan, it is very, maybe I shouldn't say very. It was very common about 20 years ago, not as much when I practice today, but it's still not unusual that if I'm talking with a cancer patient, the family has said we do not want them to know their terminal diagnosis because it will have them give up hope. And even in the United States, where it's less usual, we still can withhold information, not reveal the diagnosis if the family has said, we feel that it would be harmful for the patient to know that they're terminally ill. Okay. Again, much more common in cultures outside the United States, but also in the United States, we don't have to reveal a diagnosis. But if we're asked, then in the United States, we definitely have to say something. In Japan and India, when I'm practicing, I can still kind of get around it a little bit. Um, the duty not to deceive. The example is the use of placebos, where the patient believes they're receiving a medication versus a clinical trial where they're informed that they may receive an experimental medication or a placebo. We know that there's a placebo effect. Okay, it's well established in the literature. If you give a patient a pill and say, this will help you with your pain, and there's no, it is a placebo. There's just sugar. Okay, 30% of patients, okay, with a sugar pill will have relief of their pain just because of the expectation. We call it an expectation effect that we've said, this will help you with the pain. Okay. I believe you. You're a nurse. You're trustworthy. Okay. Um, but we do have now more the duty not to deceive. So we can't give placebos anymore. And again, we do need to reveal a diagnosis if asked. Yeah. The next one is privacy. So, loss of privacy occurs if others use several forms of access to a person inappropriately. For example, access to the physical body, access to personal information, and access to solitude. Now, kind of going hand in hand with this one is confidentiality, which is a holding disclosed information in confidence. So the arguments for privacy is certainly respect for autonomy. Okay, someone has the right over self and the right to protect access to self. The arguments for privacy is respectful care. Patients' characteristics that don't affect care should not be discussed or otherwise shared unnecessarily. So, what would be potential reasons that you could think of to override privacy or confidentiality? What would be some reasons for a nurse to override privacy and confidentiality?
Something is crisis in life threatening of the patients. So we might cross the line of the privacy and save the health of the life of patients. So.
Good. Yep. What would be some other reasons that you could potentially override privacy or confidentiality? Yeah, life-threatening.
If we do the research and we got the approval from IRB, and that's right, to access the electronic health records, I can share my experience.
Okay, please.
That's happened in the US.
Yeah.
IRB violation.
Oh no.
It's me. The things that happen because it's limit access.
Okay.
But I have there's two login name.
Yep.
This is the things happen. I work as a volunteer in the hospital at Sparrow.
Mm-hmm.
One username. And then I work as a researcher.
Ah, got it.
There's a two username
Correct.
and EMR.
Correct.
So when I access with a researcher in the cancer center, everything that's fine.
Correct.
I broke the law
Yeah.
that, because I don't know it. As a nurse here in Thailand, we can do it.
Correct.
As a researcher,
Right.
I forgot what day for my follow-up. And I used the pin, I mean
Research worth
the research.
to
And
access your own.
I access to my own data record. So it's an IRB violation to my
Correct.
university.
Yes. That's a good example. Thank you for sharing. In the United States context, we also, and I don't know about Thailand, so you have to share with me, we also have mandatory reporting. So this is a time that we can violate privacy and confidentiality. So, for example, child abuse. We must report child abuse. So if we come across that, or if we have a gunshot, which is a U.S. problem, then that's mandatory reporting as well. And then some communicable diseases are mandatory reporting if it's gonna spread. Yeah. During outbreaks. So that would be, a time because then we need to put someone in quarantine. So if they have a communicable disease that we know is a problem and we have to put them in quarantine, then we can break. So, but privacy and confidentiality is really, a very important, nurse patient ethical principle, but there are a couple of times where we can break it. Yeah. Okay. So fidelity. Oh, and I'm looking at my time. I'm talking a little bit more. Is it okay if we go a little past 3 o'clock? Okay. Thank you. Um, the other principle here is fidelity, trust to act in good faith and loyalty. So the reasons for fidelity are the public has a right to expect a standard of behavior from a healthcare professional, such as to expect gentle, non-judgmental care, and a belief in the relationship based on fidelity is necessary for patients and their families to entrust their health care to a nurse or other healthcare professional. So some of the reasons for fidelity is that a belief in the relationship, again, is necessary for patients and their families to entrust their health care to a nurse. So thinking about that, okay, what are some possible reasons for a nurse to override fidelity? Huh? So let me put it this way, when can you abandon care of a patient? That would be the time that you aren't going to act in good faith, loyalty, and trust to a patient. When is it permissible for you to abandon care of a patient? But actually, yes, that is correct. Personal safety. That's one time that you're able to abandon care of a patient is personal safety. Aggressiveness, but also such as a fire. Okay. We've um, in Japan, a typhoon when the water was an earthquake happened and the water was coming and there was flooding. Hmm? The tsunami. So those are the only times really that you can abandon care of a patient is when you're in personal danger. Yeah, good. Okay. Maybe I won't keep you that much over 3 o'clock. So now what we're going to do is we're going to talk a little bit about um, clinical ethics. So what we have talked about right now is that we reviewed a very brief history of ethics, and then we talked about the basic ethical principles, okay? And now we're going to build on that foundation, and we're going to go to a framework for clinical ethical decision making, which is what we're going to do. And this came about because just principalism alone, okay, um, didn't really provide enough structure and guidance to be able to make those decisions about whether or not to help someone continue with dialysis or not. Okay, so how can we do balance principalism with judgment, clinical judgment, and morals? So that's how this came about. So let's do a case together. So we're going to talk about Mr. A, and he is a 62-year-old carpenter, and he has been seen by his doctor for several years for emphysema. And the emphysema now has become quite severe. In the last year, he's had to be hospitalized about every other month, so 6 times for severe exacerbations of his disease, but so far hasn't required ventilator support. He is divorced, has a grown son and 2 daughters, but has been living with a female companion for about 6 years, but not married to her. He has been a heavy smoker since his teens, but quit 4 years ago. So in June, this summer, he was admitted to the hospital with pneumonia. When a chest x-ray was taken, there was a lesion on the left lung, and a biopsy is ordered. And during the biopsy, Mr. A suffers a pneumothorax and is intubated. He experiences cardiac arrhythmias, and the biopsy comes back positive for adenocarcinoma. So he has lung cancer. So Mr. A is informed that he has lung cancer, and his doctor explains that his condition and prognosis is not great. And in the course of the discussion, he asked Mr. A if he desires a DNR, desires to be resuscitated if he suffers a cardiac arrest. If not, then the doctor will write a do not resuscitate order. But Mr. A says, I want resuscitation. So he doesn't get a DNR. Within a week, not surprising, Mr. A develops symptoms consistent with adult respiratory distress syndrome, okay, ARDS, which is common given, what he is going through. He becomes and is no longer able to communicate, and renal function deteriorates and dialysis is indicated. His doctor confers with Mrs. A's female companion and recommends that dialysis not be initiated. She concurs with that recommendation. However, Mr. A's son and daughter strongly insist that everything be done because they recall his refusal of a DNR and states that he was a strong man and a fighter who would want to live even if it meant fighting cancer. Okay, so let's talk about this. What do you think? What should be done for the patient? Thinking of just principalism. What about autonomy?
I have a question.
Mm-hmm.
I have a question. This is the US
Yes.
culture. So if you stay with someone as a partner,
Yeah.
is it legal for your partner to make a decision?
That's a good question. It depends on the state, which makes it even more complicated in the United States. So the US situation is a challenge. So to answer your question simply, in states have different numbers of years. If you live together, you're then considered like married. Okay, so we'll say in this case, 6 years is long enough in the state that they're in. Good question. But we can discuss it either way. Actually, we can discuss it either way. Yeah.
Because I have something to think about. Because for the patients without any signs of DNR,
Yeah.
and then if he cannot make decisions, we're
Mhm.
going to give the decisions to
Correct.
his partner.
Correct.
And so the situations are going to be happen because for their children, when they live far away,
Yeah.
and so it seems like they feel like, oh, I need more time
Correct.
to stay with my parents or
Yeah.
give something return.
Mhm.
But in the real life, if we do something like help him to fight with cancer
Right.
and dialysis,
Right.
it should be like no more than 1 month that their children can live together with their parents.
Mhm.
But all of the caregiving is gonna dump to his partner.
Correct. Yeah.
So it should be family consultation or
Mhm.
family counseling, like a
Correct.
whole family.
Correct. And thank you for bringing that up because as a palliative care nurse, this is exactly what I do is I call for a family consultation and get everybody in the room. Now, just like all of you in the Zoom room today, what often happens is the children are living far away, and so they're joining by Zoom. And they also are not there to see really how serious their father is. They're just remembering their father the last time they saw them. So that's another thing that we have to help them with. Yeah. Yeah. Okay. So what I did was Yeah, so we'll just walk through the 4 boxes and then I'll stop sharing slides so that everybody can see the screen. Okay, we'll do it that way. So, so the first box is focused on medical treatment or indications, and the underlying principles are beneficence and non-maleficence. So we're looking at what is the health problem, the diagnosis, and the prognosis. What is the range of treatment options? And what we want to do is, what is the range of treatment options? And then what we want to do is identify at least 3 that represent a highly interventionist approach where we're doing everything, and then a moderate approach, and then a non-intervention approach. And then what is the goal of each identified treatment option, and what is the likely outcome, i.e. the length of survival and symptoms. Okay. Next, patient preferences. Okay. Okay. And the underlying principle here is respect for autonomy. What are the patient preferences regarding the treatment options identified above or identified across? If the patient is unable to communicate, okay, Mr. A is no longer able to communicate preferences. Is there a verbal or written evidence? Okay, and we have verbal from his partner, and we have actually non-written because he didn't sign. Oh, thank you. So, and then if no written or verbal evidence of the patient's preference exists, is there relational evidence, which means based on how the patient lived his or her life and prior healthcare choices? Okay, so quality of life is the next one. And here again, the underlying principles are beneficence and non-maleficence. And if possible, the patient's view of his or her quality of life is respected. Consider the ability to communicate in any way, their mobility, their current and future experience of pain, pleasure, length of life, etc. And the suggestion here is to compare quality of life for each treatment option. So this is do everything. Is that better?
You want to make a bigger.
Ah, okay.
Oh, perfect. Perfect. Okay.
Okay. So and this is in between. Okay. So if we do everything, what's the quality of life? If we do nothing, what's the quality of life? And then in between. And then the last box that we focus on is contextual features. And the underlying principle is justice. So who is the primary beneficiary of the treatment? What is the impact on the family? Are the costs unduly burdensome to the patient and family? And is the public at risk? That would be like a communicable disease or something like that. So, okay. So now let's go back to Mr. A and let's think about this. So if we do everything, what might be some of the things that we do? We might. Mhm. What about the cancer? Mhm. Sorry, I'm using abbreviations. operate, OR for cancer. I love- What would be some of the other things that we would do? Yep. Mhm, mhm. I'll go dot, dot, dot.
And he want to save the patient's life with ventilator.
Mhm.
Not only, okay, not.
Yeah. Sometimes we use ECMO more and more for a lot of things. It's amazing. It's amazing. Okay. Do nothing. I mean, do nothing is really not fair because we do something, but let's just say palliative care. So we're doing. Mhm. Symptom management, and that is pain and dyspnea. Correct. Okay. So, and I'll leave the middle, the middle might be that we don't operate, but we do dialysis, we don't do chemo, those sorts of things. So you can picture the middle one. So thinking about the medical treatment and we're doing everything, what's the quality of life?
More or less backward.
Yeah, but quality of life, not extend life, but quality of life. Okay, yeah.
For patient, not for the family. Longer with the family.
Longer life.
Or do everything.
Yeah, do everything. What's the quality of life? Are they able to talk? No, they're ventilated. Are they having a lot of pain?
Sure, maybe more appropriate.
Yeah, absolutely. Absolutely. So they have longer life, but they have decreased communication ability with their patient, with their family. Also, are they going to be able to get out of the hospital? No, they have to be in the hospital. Okay. Look at palliative care symptom management. What about quality of life?
No, it should be like a slightly pain.
Yeah. Fair. We can't get rid of all pain.
Not live it.
Correct. Correct.
Not zero.
But we're better able to manage pain here than here, honestly, because here we're causing immense pain with a lot of procedures. Okay, so we have
Well,
mhm. Mhm. What else? Do they have to stay in the hospital then?
it's not necessary. Yeah.
Mhm.
If the families, they are ready and prepare the form, so we can definitely.
Yeah. Patient preferences. This is a little bit challenging with this case, which is why I like it. But we don't. So let's talk through this. What are the patient's preferences that we know?
You know that he doesn't go.
We know he said no to a DNR. What else do we know about the patient preferences? what did his 6-year partner say?
I think he gave him any.
Huh?
That's the second
She said no hemodialysis,
no chemo.
no chemo. Yeah, she said. So this is patient previous. Oh, partner. So what we know is previously when the patient was able to speak for himself, he said, no DNR. The partner, when the physician talked to her, said, I agree with you, palliative care. And the children are saying, do everything. So that's what we know about patient preferences here.
So can be
Make a list because DNR, no resuscitation, but no dialysis for his renal and no chemotherapy for his cancer. And so we have the way that can show the children symptom support. It should be some part that we treat to keep his life better.
And then this. Now, you don't have a lot of contextual features for this person that we would need to worry about here. But something that with a palliative care consult that we would do is a contextual feature here is if he lived a long way away from like a dialysis facility, or his partner lived a long way away from the hospital. That would be a contextual factor because she would have to travel a long distance to come into the hospital to visit him, or she would have to transport him a long way to get dialysis. Those would be contextual factors. The biggest contextual factor really that we have to think about that comes up in the palliative care consults is cost. Okay. In the United States context, so travel distance. Okay. These are the two most common contextual features that we're dealing with when we're talking about this. In the United States, the number one reason for people to go broke is hospital healthcare costs. Because the embarrassing thing about the United States is we don't have national health care. So if you don't have a lot of money and end up in the hospital like this, the hospital bill is unbelievably expensive. I mean, just really, really, really horrible expensive. And so the number one reason people go broke in the United States is healthcare. So this, quite honestly, is what I do with my palliative care consults is so you can see where this organizes a little bit more than principalism and helps with clinical decision making. So basically and there's no right or, again, ethics, there's no right or wrong answer, but palliative care is all about really these ethical gray areas and what should be done for the patient. And this is how we can organize how to think about it, is take a look at the medical treatment, the patient preferences, quality of life, and contextual features. So when I was thinking, and when we were emailing back and forth about elderly care and palliative care, I said, oh, if we could talk a little bit about how to organize clinical decision making using this ethical, it's called the 4-box, obviously, not a very original name, the 4-box method for clinical ethical decision making. This is, and again, because the vast majority of my patients are elderly. My sickle cell is a little younger, but hemodialysis and oncology, they're, well, for cancer, it's 55 to 75 is, the age that, where cancer usually pops up. Yeah.
For caring for elderly people.
Yes.
So I have a question because someone, when I read the book, they said like they can categorize the older adults that they're ready to die because we know that one life, one time to death, they're ready. But someone, they fear to death. And they try to do everything that preserve their life, live longer, but how many years they don't know. But someone, they have something like my hope or worry about the children. They don't want to die. They want to stay and see their children that success in their life. And how we prepare elderly people that they can smoothly and receive death as a usual. Because I know that this person, they get sick with the chronic illness, but some older adults, they do not get sick. They say like, I'm healthy. That there's no preference of death. It seems like it's fear, and it seems like the terms that they don't want to discuss with the death. How we prepare.
That's a good question. So one of the nice things, often what I find is if there's a fear of death, sometimes I wonder about their spiritual life, and also whether or not they have unresolved issues. And so then, quite honestly, it's less about the physical often, but more about, here we go. So often what I do is pull in spiritual support. So the chaplain support, I also pull in psych, a clinical psychologist to explore some of those options. And for some, for many of my elders that I work with, they really can decide when they're going to die, and they say, "I'm going to stay alive until my grandson gets married." Okay, this is my family. I have 2 sons. Neither of them have girlfriends. And my father-in-law says, I want to see that at least one of them gets married. So there's things like that often are the case. And then you say, well, we'll support you the best we can, until, well, I would have to do a very quick arranged marriage for my oldest son, but those sorts of things. But often when there's a fear of death, then it's spiritual or psych. Yeah.
Can I just share my experience? Um, I am a one child. One child is my family. I surrounded with older adults, and I would say, um, so most of them they always go to the temple, and they believe in the Buddha teachings and Buddha belief. Some, I mean, in terms of the level of the belief in religions and spirituality. Some Buddha teachings teach us die is closer and die away with us every day. So if older adults, they always could go to the temple and they have the high level of the belief and adhere in the religions, practice, things like that. So those people, they feel like, okay, die is closer every day. And so we don't know how long we're going to live in the world. So just do the best every day. So like that. So from my point of view, religions in older adult is very important. So I don't know if answer your question or not, but from my experience.
Yeah, in general, that's very true. The older you get, the more important, spiritual beliefs are. Yeah, very true. Well, thank you. I kept you about 15 minutes longer than what I promised at the beginning, but that's not too bad. But this really just kind of walking this, using this 4-box method is kind of the way we make palliative help the families and quite honestly, some of the oncology surgeons who who are going, no, I'm going to operate. Kind of walking through, what, especially, taking a look at quality of life then. Well, if you do operate and do a lung cancer surgery, what is going to be the quality of life? We're going to have chest tubes, we're going to have, those sorts of things to help. Again, there's no right or wrong answer. It's ethics. So it's all gray area, but how to make clinical decisions, what should be done, for the patient. This is what we use anyway in palliative care to kind of during the family consults, get things discussed in a more of a organized way where people can make decisions rather than just with principalism. So it goes past the principalism to applied clinical ethics. Any other questions? Yeah.
Just a short one, but
Yeah.
I used to work in CCU.
Yeah.
So, and also I have been like facing this kind of situation a lot, but sometimes like the situation is not this extreme. Like
Right. Of
maybe
course.
it's just like in the middle. So like medical treatment also benefit for the patient, but also the palliative care, especially in the older adults. Yeah, we have to like choose. Actually, that older patient can be healed, but also he or she wanna die, something like that, or maybe they cannot answer, but their family like make decision like to let them go, something like that. Yeah, but sometimes I think um it's not actually a question, but sometimes when we like um especially in Thai, like the first model that you say, like we do a lot of things and okay, and at the end we cannot do anything, so we pull up like the palliative care in this situation. Yeah, and sometimes, especially in the cardiovascular, we face a little bit of bias, like
Yes.
for the palliative care.
Correct.
So we just want to yeah.
Not just cardio, even in oncology, everywhere.
Yeah, sometimes like when the palliative care team come and okay, that means this patient is going to die like soon, something like that. Yeah, it's like this is maybe actually the condition sometimes can be healed, but okay, sometimes it's might cause a little bit like discomfort to the patient, but just the short term, yeah. Okay, but I think that in your like perspective, like how to for me, like as we talk about this case, I think sometimes when we like do the ORs, maybe the cancer can go away, something like that, and the quality of life will come back soon after that. Yeah, maybe, but maybe like very like small percentage. Yeah, but I just wanna like ask you like, and also the second question is
Can we pause
okay,
there?
just a little bit, right? Okay, this is the things that I
Answer
concern a little bit. Thank you.
move on. So hold your question
Okay,
too.
okay.
Put that in the parking lot.
Ah,
and,
okay.
and come back to that. So how do I deal with this? Um, so what we do is well, first of all, I think I'm fortunate in the United States that people are more and more moving to that model where the palliative care goes hand in hand with curative care. So it's not like, oh no, palliative care, they're dying soon. But that still happens, okay? But I think we've been doing a better job, educating to say we are that umbrella, we are that extra layer of support, and but our intent, our reason for practice, our reason for being here is to really focus on your quality of life. We're not worried about, well, I don't say we're not worried about curing you because that comes out wrong. But, we just say our focus is on helping you live the best life possible is the phrase that I use. What I say to them is, okay, what does being cured or what does better look like for you? So, if they say, okay, better for me is being able to play with my grandchildren. Better for me is being able to walk a block. Better for me is, and so I have them define what looking better looks like. Okay. And then I say, okay, let's go ahead and try this treatment. Okay. And then if it's okay with you, because I want to keep the door open. Okay. I don't want to shut the door saying, no, I'm going to do treatment. I don't want to see you again. I want to keep the door open. And then I say, well, let's check back and see how you're doing, in 3 weeks. Okay. So in 3 weeks or one, if it's community, then, I check back in actually, depending on how they're doing. Often it's weekly, um, you know. Um, then whenever I'm checking back with them, I say, so how are you doing? You told me that, okay, better would be that this is what you would be able to accomplish. Have you been able to accomplish this? So I have them decide what better is, and then we can continue the conversation. If they're getting better, it's like, yay, hallelujah. Okay, that's wonderful. Celebrate with them. And you always say, I hope that. Okay, you always say, I hope that. Okay, because getting back to something you said is that we're horrible for anyone with prognostication. Okay, we can't tell, okay, for an individual what will happen. Okay, we can tell out of 100 patients with breast cancer, okay, 80% will go into remission, 20% will not. We don't know who those 20 are. So when they get close to life, we can guess, but there's miracles that happen every day. Okay. I've seen many, 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 many miracles in my career. And I can't tell if you will be the one. So I always hope that, okay, you will be able to walk the block. I always hope that you will be the one with the miracle. But you define that, and then I check back in. And then I also say, well, I hope that for you also. but it doesn't look like this is happening. Or the miracle that, because I come from a Christian tradition, which is a little bit, actually, Christians are decreasing in the United States, but there's still the majority is Christian. What I say is that the miracle that I see most often is that Jesus will come to take you home. Okay. So, so we always hope with the patient, but then we also have them define what does getting better look like. And then you can say, well, yeah, it looks like you're getting better. Or, you know what? You're not walking that block. So let's talk a little bit more. Now, second question.
So, okay, I'm a Christian also, so I know about the miracle. So sometimes we do something like on the left side for hoping for the miracle. But my next question, I think this one, like this 4 box, like, I think I know that you don't do this like just one time. Maybe
Yeah.
you do it like many
It's an
times to check
ongoing
like,
conversation. Yeah.
follow up one. So, but sometimes like based on your experience, when we do something like this, is it like I think there might be some like arguing like during the session that we talk about this, like there are children might not agree with the partner or something like that. And who will be deciding like which way should we go? Should be the one or based on the law or something? I don't know. Yeah.
In this case, it is the law.
Okay.
Yeah. So we do have a decision rank of who makes the decision. So in this case, if Mr. A was living in a state where the long 6-year partner, okay, meant that they are then legally able to make decisions, we would go with her. The District of Columbia, Washington, the District of Columbia, Washington, D.C., it's 7 years.
Mm.
Okay, so then she would not be able to make the decision and we would have to go with the children. So then I would spend a lot more time with the children saying, are you able to fly in? Are you able to spend months here? And then I try to have them take more responsibility then. If they're going to be the ones who say we want everything done, well then are you going to be the one taking care? And so then I talk about context. Okay, are you going to pay the bill?
Especially the cost, the bill.
Okay. Are you going to pay the bill and are you going to be the one taking care? And I'm pretty upfront and also say, so do you have, because 1 month in a hospital can be more than $100,000, especially at the ICU in the United States. So how much money do you have? How much money does your father have? Do you want any inheritance or do you want a bill?
They can be a homeless. That's all.
And I talk about the number one reason for bankruptcy in the United States is exactly what you're choosing for your father. And that's not bad. That's not a bad choice. It's never a bad choice, but it should be an informed choice. So how much vacation time do you have? Is this how you're going to spend your vacation time? And maybe the answer is yes. Maybe they will fly in, and maybe they will take care. But we do have a quite a frank, honest discussion about that.
I know that someone gonna be take care because one man that I met him on the rescue mission,
Ah,
he's
okay.
homeless.
Yep.
He broke because of the cost of care that he treat for his mom,
Mm.
and he quit the job to take
Mm.
care of his mom because he said like whatever that he
Second
can
victim.
spend the time before his mom passed away. You
Mm.
do.
Correct. Yep.
It's their choice.
It is. It is their choice. So you support them no matter what the choice is, but you help them make this clinical decision, that with as much information as you can provide, and then support whatever decision comes out. Because again, there's no right or wrong.
Mm.
Yeah.
Thank
Did
you.
that get
Yeah.
all your questions
Thank
answered?
you very much. I think we should do the advanced care plan at
Oh,
first before
absolutely.
something like this happen. Okay.
Yeah.
Thank you very much.
Yeah, but advanced care plan it would come under patient preferences.
Mm.
Okay, so if there was an advanced care plan, that would be under patient preferences. We know, but he didn't sign the DNR, which makes this a little bit more of a complex case, which is why I like using it as an example. Because if they have an advanced care plan, we know what the patient preferences are because it is all in writing. Yeah. Well, thank you. Thank you.
Palliative care.
Like certification in palliative care.
Correct.
Is still access right now?
Huh?
Is still access right now?
Mhm.
Yeah.
And
And
what
what's
mine?
it for free? For free.
I got it. LNAC.
Yep, LDAC training is palliative care as well. But LNAC doesn't cover this four-box method of clinical decision making, actually. Yeah. So I've talked to Betty a few times. Betty Farrell is the developer of LNAC, and she's a friend of Bill and Barb, as well as mine. And so I've told her we really need to build health ethics for LNAC and include this four-box method. Yeah. Well, thank you. And I'm very sad to say this is Friday afternoon, and and I'm going to be flying back to Chicago late tomorrow night, early Sunday morning, so that I can be back in my office on the 10th floor of the College of Nursing building Monday morning at 7 a.m. So.
Might not 20 degrees.
Please don't say that. But yes.
No storm now. No storm.
Yes, yeah, polar vortex this year.
Before we leave and say thank you to you, I just want to share the palliative care in the Thai context a little bit. It's my difference from the Western a little bit in terms of autonomy. So in the Westerns, the patients and the palliative care, the autonomy is kind of individual center. So the Western people have the self-determinations. Well, but in Thailand, some older adults, they always say, okay, it depends on my children. I don't know. Yeah, it's special. I don't want to burden my children. It depends on the burdens. So it's kind of challenge for us to investigate the real preference of older adults and the patients as well. And yeah, so this my thought like, okay, it's very some kind like cultural sensitive thing about exploring the patient's preference in my culture as well. And also in terms of the decision making as well. So yeah. No, it's not my way. Thank you for inviting. But I can help you, but it's not my way. But I like this question about the ethical palliative care as well. And thank you so much, Dr. Ardith. We are like my thought and our class as well. So we learned a lot how to apply the frameworks of decision making in palliative care in not only older adult, but also the patients with any kind of critical problem as well. And also ethical palliative care is dilemma. So it's not no right, no wrong, depends on the context, and we explore about patients preference and also the family as well. So thank you so much.